Welcome to the Platelet Couch. My name is Fazan Sattar. I'm a Senior Medical Science Liaison with SOBI North America. Today, joining me is Dr. Lamiaa Tolba, Physician Assistant in Charlotte, North Carolina. Thank you so much for joining us, Dr. Tolba.
Thank you for having me.
For sure. And so we're going to be discussing a patient case series about ITP. To start off, how did this patient present with ITP?
So he presented with the clavicle fracture, and his provider noticed that he has a lot of petechial rash. So the provider obtained the CBC to see what's going on with his petechial rash. They thought his platelet count might be low, and he was ITP. In that case, the platelet count was very low.
Okay. Then how did this patient present to you then?
So he was seeing a different hematology oncology, and he tried the first line with high-dose steroid, did the dexamethasone for 4 days, didn't respond or sustain the response, and got rituximab, the 375 milligram per meter square, weekly for 4 weeks, still did not respond. He also failed Lamiaa. Here he's on fostamatinib for 100 milligram twice a day for 2 weeks, and because he failed so many, and the provider felt like he's running out of options, he referred him to us in classical hematology to see what other options it could be for him.
Okay. When you took over care for the patient, how did you approach their case?
So because he was already on fostamatinib, but it wasn't enough time for me to say, yeah, he failed it or not. We continued the medicine, the fostamatinib, for 2 more weeks at 100 milligram twice a day. And then we brought him back to clinic for platelet count or CBC check, and his platelet count was still pretty low. So per PI or prescriber information, next step is to adjust his dose up to 150 milligram of fostamatinib twice a day, and then remeasure a month later. But at that time, when we go up, that's like since it's our last step, our way of dealing with our patients is we already discussed what's next, because almost all of them will ask me that question. If this doesn't work, then what? It seems to be to help them kind of have a roadmap for themselves. So I make it for me to talk with my patients, what's next, what's the options that are available out there. At that time, we didn't know the Doptelet was available for ITP. We knew about it being for chronic liver disease, but we weren't aware of it available for ITP approval. So we were talking to him already about cyclophosphamide or other chemotherapy and immunosuppressives. And then he was kind of not happy about having to have that such suppression of his immune system. So when he came back for his platelet count and it was still low on the 150 milligram twice a day of fostamatinib, we discussed with him Doptelet, and he was actually very happy that he has another option he can try.
Could you give us a little bit more information about why Doptelet was chosen as a therapeutic option for the patient?
For this specific patient, it was because he really didn't have anything. He tried everything else per se. So the introduction that's his last option for this specific patient. Almost all the other ones is like 1 or 2 steps only. Having Doptelet have more options with dosing also was it made him optimistic that this might work for him as well.
Now that you have the option of Doptelet, how did the patient respond to it?
So his response was actually very good. We brought him back and to monitor his platelet count frequently to make sure it doesn't go too high, but at the same time we adjust the dose appropriately without him being with low platelets for too long. And he responded very well. We had to do a couple dose adjustment up and down for us to find the right one for him. But very shortly after he started, we were able to find the right dose for him.
Since starting Doptelet, how long has a patient been on Doptelet?
It's 2 years from the day one of starting, but it's maybe 22 months from when we got to the final dose that he's on right now.
Okay. And what are the key takeaways from this patient experience that you had with Doptelet?
The key takeaway is you need to know what the patient is, what's important for the patient. So we make sure that they know what's available for them out there, especially if somebody haven't tried out the options yet, except of course the high-dose steroids. So we want to make sure they understand how each medicine is being taken. The Doptelet is very favorable with a lot of my patients because of the restrictions and they're not there, so they don't have to put timers on their phone to wake up at 3 in the morning, for example, or if they're working and they live on milkshakes or things like that. And I've had these situations happening before, so that's why I like Doptelet a lot for my patients.
Yeah, perfect. Thank you so much for joining us, Dr. Tolba, on the Platelet Couch today.
Thank you.
Please do watch the other videos in the series as well. Thank you so much for joining us today.
Doptelet, avatrombopag, is indicated for the treatment of thrombocytopenia in adult patients with chronic liver disease who are scheduled to undergo a procedure, and in adult patients with chronic immune thrombocytopenia who have had an insufficient response to a previous treatment. Before taking Doptelet, tell your healthcare provider about all your medical conditions, including if you ever had a blood clot, are pregnant, or plan to become pregnant. Doptelet may harm your unborn baby. Tell your healthcare provider if you become pregnant or think you may be pregnant during the treatment with Doptelet. Also tell your doctor if you are breastfeeding or plan to breastfeed. It is not known if Doptelet passes onto your breast milk. Do not breastfeed during treatment with Doptelet and for at least 2 weeks after the last dose. Talk to your healthcare provider about the best way to feed your baby during this time. Tell your healthcare provider about all the medicines that you take, including prescription and over-the-counter medications, vitamins, herbal supplements. Doptelet may affect the way other medications work, and other medications may also affect the way Doptelet works. TPO receptor agonists have been associated with thromboembolic complications in patients with chronic ITP. Thromboembolic events, arterial and venous, have been reported in patients with chronic ITP treated with TPO receptor agonists. Consider the potential increase in thrombotic risk when administering Doptelet to patients with known risk factors for thromboembolism, including genetic prothrombotic conditions and acquired risk factors. Monitor platelet counts for signs and symptoms of thromboembolic events, and institute treatment promptly. Serious adverse reactions that have occurred more frequently in patients treated with Doptelet compared to placebo was headache. The most common adverse reaction, occurring in 10% or more of patients with chronic ITP, were headache, fatigue, contusion, epistaxis, upper respiratory tract infection, arthralgia, gingival bleeding, petechiae, and nasopharyngitis.